Hello, everybody, and welcome back to BioSC 140 Human Physiology. This is part four of the blood lectures. So let's get right into it. Oxygen carrying capacity of blood is determined by several factors. So I mentioned before that oxygen is not very soluble in water in aqueous environments. And so our bodies have developed a way to increase the amount of oxygen that we can have within our bloodstreams to, carry oxygen around to all the cells that need it. There's several factors that affect this carrying capacity. One is the number of red blood cells, just the sheer number. Typically, there's around 5 million per microliter. The concentration of hemoglobin, HB is hemoglobin, and these brackets, again, signify concentration. So the concentration of hemoglobin, about 14 grams per deciliter, about 280 million molecules per cell. 280 million per cell. And remember, each one of those molecules holds onto 4 oxygen molecules. Each one of those hemoglobins holds onto 4 oxygen molecules. And then hematocrit, or HCT. Hematocrit is the packed cell volume of a centrifuged sample of blood. So we would do this in lab if we were meeting in person. We'll talk about this in lab. So what hematocrit is you take a capillary tube, you take a tube of blood and you spin it in a centrifuge. That centrifuge produces centrifugal force, which is going to push all of the formed elements, all of the red cells and white cells, to the outside of the tube, and you're going to end up with two distinct layers in that tube. You're going to have the plasma layer, this yellowish, clearish layer on top, and then a red layer on bottom. And hematocrit is what percentage of the whole is that packed cell volume. So hematocrit is equal to packed RBC volume divided by total blood volume. So this section down here divided by the whole. Really, it's what. So earlier on in the blood lecture, I talked about how the formed elements, how red blood cells make up a certain percentage of whole blood, and I said it varies. We said 40%, we said 42%, we said 38%. That's hematocrit. What percentage of the whole are red blood cells? And that number does vary. Normal is around 42%. Anything below 37% is considered anemic. Know this number. Anything 37 or below is anemic. All right, so hemoglobin is the main component of red blood cells. Hemoglobin, 280 million per red blood cell, about 14 grams per deciliter. Structure. This is kind of review still. It's a tetramer structure. 2 alpha subunits, 2 beta subunits. Each individual subunit has a heme group. So 4 heme groups per hemoglobin. Each heme group holds onto 1 oxygen molecule. So 4 heme groups, 4 oxygen molecules can be held onto in a hemoglobin molecule. Hemoglobin is a buffer, and it is a carrier protein. Oxygen saturation is an important thing to understand. So this is something that you're going to see in nursing school if you go that route. This is something that's really common, that's going to come up commonly in the healthcare world. And that's oxygen saturation. I can pretty much guarantee you that there's going to be questions on oxygen saturation on the checkups and on the exam. So oxygen saturation is what percentage of those sites are occupied by oxygen molecules. An example, if 3 out of every 4 heme molecules were bound to oxygen, 3/4 were bound to oxygen, we'd have 75% saturation. If we have one hemoglobin molecule, there's 4 possible binding sites. If all 4 hemoglobin molecules were bound to oxygen, we could say that it was 100% saturated. If we had one hemoglobin molecule and 3 oxygens were bound to it, that's 3 out of a possible 4. We could say it's 75% saturated. If we had one hemoglobin molecule and there were 2 oxygen molecules bound to it, that's 2 out of 4. We could say it's 50% saturated. Now, there's not just one hemoglobin molecule in our bodies. And so in a clinical setting, we're not talking about one hemoglobin molecule. We're talking about millions, hundreds of millions, 280 million per red blood cell. So we're talking about very large numbers. What percentage of those possible binding sites have oxygen bound to it? Let's do a practice problem. If I had 10 hemoglobin molecules, how many oxygen molecules could possibly be bound to it? What's the maximum number of oxygen molecules that could bind to 10 hemoglobin molecules? All right, so each hemoglobin molecule can have 4 oxygens bound to it. So 4 times 10 hemoglobin molecules is going to give us 40 possible oxygen molecules bound to that hemoglobin if it's 100% saturation. If we have 10 hemoglobin molecules and it is 75% saturated, it is 75% saturated, 10 hemoglobin molecules, 75% saturated, how many oxygen molecules are bound to those hemoglobin molecules? So 100% is 4 times 10, so that gives us 100% saturation. So 40 molecules is 100% saturated. What's 75% of that? 30. 30 oxygen molecules are bound to those hemoglobin molecules. Be ready for questions like that. If I had one whole red blood cell and there's 280 million hemoglobins in that one red blood cell, what would the saturation be if we had, if that red blood cell was, just to make the math easy, 25% saturated? So 280 million hemoglobin molecules, 25% oxygen saturation on all 280 million hemoglobin molecules. How many oxygen molecules are bound within that red blood cell? So let's take 4 possible hemoglobin molecules per, 4 possible oxygen molecules per hemoglobin molecule. Let's multiply it by the 25%. So 25% would give us 1 oxygen molecule per hemoglobin. And then, so 1 oxygen molecule per hemoglobin, we have 280 million hemoglobin. So 1 times 280 million would give us 280 million oxygen molecules bound within that red blood cell. Be ready for questions like that. So oxygen saturation actually will change throughout our circulatory system. So at our lungs in a normal, that's where that's where oxygen is going to be coming into our circulatory system, into our blood, and binding onto these hemoglobin molecules in our lungs. In our lungs, our blood is going to be about 99, pretty close to 100% saturated in most situations, in normal situations. Now, that oxygen is going to stay in our blood until it gets to capillaries. Capillaries, we're going to learn about soon. They're the smallest blood vessels within our circulatory system. And that's the place where oxygen moves in and out, or moves out of our bloodstream. In a normal situation, about 30% of that oxygen that is in our bloodstream is going to move out into our tissues. About 30% is going to move out into our tissues. Now, this varies in different situations, but at rest, that's a good guesstimation. So in our lungs, our blood picks up oxygen. We get to 99% saturation. That blood is 99% saturated until it gets to the site of gas exchange, the capillaries. And around 30% of that oxygen is going to leave the bloodstream and go into our tissues. We're going to have about 70% saturated blood in our venous system as the blood returns back to our heart and then goes into our pulmonary artery and back to our lungs to pick up more oxygen. Our bodies can tolerate 30% saturation for short periods of time. For long periods of time, we need at least 50% saturation. Anemias have reduced oxygen carrying capacity. Anemias are caused by low red blood cell numbers, insufficient hemoglobin, so not enough hemoglobin, or inadequate hemoglobin. And they're characterized by a compromised ability to carry oxygen. Anybody who has anemia has a compromised ability to carry oxygen. Indicators, low red blood cell count. So if you took a standard blood panel, you did standard blood labs on a patient in front of you, and you noticed they had too low of red blood cell count, think anemia, too low hemoglobin concentration, or too low of hematocrit, think anemia. Anemias result from a number of deficiencies. So there's a number of different things that can lead to low red blood cell number, insufficient hemoglobin concentration, or inadequate hemoglobin quality. So when it comes to red cell number, when it comes to reduced red cell number, think about where red cells come from. They're produced at a certain rate. They live for 90 days, and then they're destroyed at a certain rate. There's a balance. The rate of production is equal to the rate of destruction. If one of those rates gets thrown off, if you decrease the rate of production, but you keep the rate of destruction the same, you're going to have a decreased number of red blood cells overall. You're going to have anemia. If you keep production the same, but you have an increase in destruction, you're going to throw that balance off again, and you're going to lead to a reduced number of red blood cells. Decreased production could be because of dietary deficiencies. Not enough iron. B12, pernicious anemia, lack of B12, or lack of folic acid. Dietary deficiencies in any one of these three could lead to a decrease in production of red cells. Bone marrow disease. So think about where these red cells are produced. They're produced in bone marrow. If there's a disease of the bone marrow, it could reduce the number of red blood cells produced. Or inadequate EPO, erythropoietin. Remember, from hematopoiesis lecture. EPO stimulates the production of red cells. Increased destruction or loss. Increased destruction or loss. Now, how would you lose red blood cells? Well, bleeding, so blood loss, menstruation, ulcers, blood loss. And it really doesn't take a lot of blood loss. A very small amount of blood loss, like during menstruation, can cause some anemia. Weakened red blood cells might lead to premature destruction, like hereditary spherocytosis. Here's a picture of a red blood cell. So sphero is like sphere, cytosis cell, like it doesn't have the normal shape, and it's prone to early destruction. Insufficient hemoglobin. So remember, there's an iron molecule in each heme group. If we don't have enough iron, we can't produce hemoglobin. So insufficient iron, insufficient hemoglobin. Inadequate hemoglobin would be quality problem. A quality problem of the hemoglobin. Sickle cell anemia is an example of that. Here's a picture of a sickle cell. Anemias there's kind of two different naming classifications, two different ways to name anemias. Some names for anemias talk about what's causing that anemia, like iron deficient anemia. It's because you don't have enough iron. Pernicious anemia, you don't have enough vitamin B12. Other naming characteristics for anemia refer to the cell size and the color of the cell. Now, typically when a patient comes in, they don't just show up at your office and their first time they come in with a complaint, they say, oh, I have iron deficient anemia. You have to go through the process of figuring out that that's what that patient has. So the patient comes in, you run some blood work. You send, the blood sample to the lab. They, look at the red blood cells, and they'll actually look at the red blood cells, and in the report back to the doctor, they'll say, oh, you have macrocytic or microcytic or normocytic red blood cells. And they'll usually use both of these terms. They'll say on the report, you have microcytic normochromic red blood cells. The sample has macrocytic hyperchromic red blood cells. So microcytic too small, normochromic just right, macrocytic too big, hypochromic too little of hemoglobin. So hemoglobin helps impart the color on the red blood cells. So hypochromic, not enough color, which translates to too little hemoglobin, normochromic and hyperchromic. So they'll use one word to describe the size of the cell and one word to describe the amount of hemoglobin or the color of the red blood cells in that sample. So the anemia names that describe what the cell looks like can help the doctor then figure out exactly what's causing it. So, iron deficient anemia is going to kind of tell you the cause. A microcytic hypochromic anemia is going to more describe what the cells look like and not so much the cause of it. But knowing what the cells look like can help the doctor narrow down his differential diagnosis list and get to a point where he knows what's causing the anemia. So anemias are described using a combination of RBC size and color. Let's do a practice question. How would you describe this cell right here? If I told you that the red blood cells in your patient's sample were too large and pale in color, what two words would you use to describe that red blood cell. Well, macrocytic, too large, pale in color, hypochromic. Iron deficiency is the most prevalent cause of anemia. Iron deficient anemia tells you what's causing it. Iron deficient anemias are characterized by being microcytic hypochromic. Microcytic hypochromic. It's the most prevalent type of anemia, iron deficiency, and it could be a dietary issue. It could also be a chronic infection issue. One way that your body helps fight long-lasting infection is it sequesters iron in your liver, and it kind of tries to starve out the pathogen by reducing the amount of iron that can go to it. It can lead to iron deficient anemia. Look at these prevalence numbers. Women, 20%, iron deficient. Men, 3%. Children, 20%. Pregnant women, 50%. Pregnant women have to eat for 2 people. Their blood supply increases. Their weight increases. Iron deficient anemia is really common. Another one is pernicious anemia. Pernicious anemia. Now, pernicious anemia, we talked about this a little bit when we talked about digestion. Vitamin B12, cobalamin, it needs a special molecule, a helper protein to help absorb it in your intestines. And sometimes people have absorption issues when it comes to B12, which can lead to pernicious anemia. Sometimes it's a dietary deficiency, and that's usually vegans. Anybody who's a vegan probably knows a lot about vitamin B12 because it's something that vegans need to be careful about. They need a supplement, or they need to eat specific foods that contain B12, because I think there's only a couple like really vegan friendly sources. Vitamins, so supplementation, brewer's yeast, or no, not the brewer's yeast, dietary yeast. Dietary yeast, if you haven't tried it, it tastes kind of like cheese. It's pretty good. I think it's kind of funny that my favorite thing to put it on is eggs, which isn't vegan friendly, but it's a different issue. I think there's some seaweeds also, like nori, some seaweeds that have some B12 that are vegan friendly also. All right. So variation in blood cell numbers can be normal physiologic responses. So let's look at red blood cells first. And so if we have this is kind of pathology more so than physiology, but I still think it's good to think about. Variations in number of red blood cells. If a patient has too many red blood cells, as with polycythemia vera, you can have an increase in blood viscosity. You can have an increase in blood viscosity. Now, when you have an increase in blood viscosity, your blood is thicker. It's like drinking a milkshake through a straw compared to drinking water through a straw. When your blood is thick, it makes your heart work harder. So it can be tough on your heart. It also increases your odds of having clotting issues, of thrombus. But if it's a small amount and it's because you're an athlete who's training in Tahoe or Colorado, it can be totally normal to have a slight increased number of red blood cells. If you have polycythemia vera because of a myeloproliferative disorder, not a good issue. If you have it because you're a smoker, not a good issue. Not good. What about if you have too little red blood cells? If you have too few red blood cells, it can cause anemia. It can cause anemia, so not a good situation. So too many red blood cells, sometimes okay if you're an athlete training in a certain situation. Sometimes bad. Anemia, generally not good. What about if you have too many white blood cells? Well, let's say you get an infection. Do you want to increase the number of white cells to fight that infection? Yeah, absolutely. Absolutely. So too many white cells is okay in that situation um, to fight infection. So in our white cell lab, we actually figure out how many white cells are in each other's blood. And I remember this one semester, this one student had like twice the normal amount. And I always tell people in lab, don't diagnose yourselves. Our equipment isn't perfect. We're still students. Don't diagnose yourself in lab. But this one student had like a pretty high white blood cell count. And then I get an email the next day saying that he's going to miss class because he's sick. So if you have too many white blood cells because your white blood cells are fighting an infection, totally fine. If you have too many white blood cells because you have leukemia, not a good thing. Not good if you have leukemia. So a myeloid issue is going to refer to a bone marrow issue. And red blood cells, white blood cells, and platelets are all made in the bone marrow. So myeloid issues tend to increase numbers of red blood cells, white blood cells, and platelets. Lymphoid issues only tend to affect affect white blood cells. So it just helps you diagnose, helps you know where to look for the issue. If your patient has too many red blood cells, white blood cells, and platelets, you might be looking at a bone marrow issue. If your patient just has too many white blood cells, look for a lymph thing. So leukemia is the proliferation of white blood cells, kind of associated with, people think, cancer. So too many white blood cells. And usually with leukemia, you're not really making effective white blood cells. And so that's not a good thing. Too few white blood cells is always a bad thing. Too few white blood cells is always a bad thing. It's always pathological, and it means that person is immunocompromised. They do not have a normal functioning immune system. Too many platelets, so thrombocytosis. It's going to be an increased clotting. If you're injured and your body is responding to an injury, totally fine. It can be a bad thing, though, if you're causing thrombosis. Thrombopenia, you have a decreased clotting ability. It's not a good thing. Hemophilia. So hemophilia, people with that, they get a paper cut and they just bleed and bleed and bleed, and it doesn't clot normally. It's not a good thing. All right, so white blood cells provide immunity. White blood cells provide immunity. So white blood cells, leukocytes, or WBCs are all the same thing, different words for the same thing. And they're kind of broken up into two main categories, granulocytes and agranulocytes. So granulocytes have cytoplasmic granules, as the name would imply, and there are three subtypes: neutrophils, eosinophils, and basophils. Agranulocytes have no cytoplasmic granules, and there are two subtypes: lymphocytes and monocytes. Of the white blood cells, neutrophils are the most prolific, the most common, the most abundant. 60 to 70% of all white blood cells are neutrophils. Physical characteristics: they have neutral staining granules and a multi-lobed nucleus. You can see this multi-lobed nucleus. They have a very short lifespan. They do not live very long. They are capable of diapedesis. So this is a vocab word. Make a flashcard for this one. Diapedesis means they can squeeze through capillaries into tissues to fight infection. So the circulatory system provides a highway for them to get around our body, And then they are able to diapodese or squeeze out of capillaries into tissues to help fight infection. Neutrophils uh, are able to engulf and destroy other cells, mainly bacteria. They phagocytose. They are associated with bacterial infection. If your patient is sick in front of you and you do blood work on them and you notice that they have increased number of neutrophils, you're going to think this person has an increased number of neutrophils because they are trying to fight a bacterial infection, associated with bacterial infection. Eosinophils fight parasympathetic infections. Sorry, not parasitic infections and prevent hypersensitivity. So about 2 to 4% of all white blood cells, so a much smaller percentage than the neutrophils. Physical characteristics, they're reddish staining granules, and a bilobed nucleus. They are capable of diapodesis, and they are associated with fighting parasitic infections and protecting against hypersensitivity, so antihistamines. Increased number, so if you have a sick patient in front of you and you see they have an increased number of eosinophils, you might think parasitic infection. Got to look into it. Bassephils stimulate allergic reactions. Bassephils stimulate allergic reactions. They're a very small percentage of our white blood cells. They are dark purple staining granules. They have S-shaped nuclei, and they do not undergo diapodesis. Functional overlap with mast cells. Function is enhance allergic or inflammatory response. So they enhance the response. White blood cells work in teams. They all help each other. And basophils help by enhancing the allergic or inflammatory response. They release histamine, which causes vasodilation, which allows for more white blood cells to flow to the area. They release serotonin, which increases capillary permeability so we can have more diapodesis, more nutrients flowing into the interstitial space. And they release heparin, which is an anticoagulant. Monocytes are precursors to macrophages. Around 3 to 8% of all white blood cells are monocytes. Physical characteristics, they're large, pale, and they have bean-shaped nuclei. They're produced in lymph and bone marrow. They're the strongest, they're long-lasting of white blood cells. They're capable of diapodesis, and when they enter tissues, they change their name, they become macrophages. So macro is big, phages eat. They're big eaters. They fight infection. They're stronger and more effective than neutrophils, but they're slower to respond. So neutrophils are the quick-acting, fast-acting. These are slower to respond, but they're stronger and more effective than neutrophils. You can see here, this macrophage is starting to engulf a cell. Increased number would be a chronic or long-lasting infection. Chronic or long-lasting infection. Lymphocytes produce antibodies and enable immunomemory. So 20 to 25% of all white blood cells. They're the smallest white blood cells. They have large, dark staining nuclei. They're produced in lymph and bone marrow. They are capable of diapodesis. And there's various subtypes. So T cells mature in the thymus, B cells mature in the bone marrow. Functions, they make antibodies to fight specific infections. So we've talked about antibodies already in this lecture and before in this class. Antibodies bind onto very, very specific, they'll, they'll bind onto a specific part of a specific protein on a specific virus or bacteria. They allow for immunomemory. They also have some issues with organ rejection in transplants. When you get chicken pox, you only get chicken pox one time because lymphocytes learn how to produce the antibodies that will protect you from the chicken pox in the future. When you take a vaccine, you are training your lymphocytes to produce specific antibodies to protect you from whatever that vaccine is meant to protect you from. So with everything going on in the world, with the pandemic right now, a lot of people are spending a lot of money and a lot of time trying to figure out vaccines to help us all out. And they're trying to figure out ways to train these cells, to train lymphocytes to produce an antibody that can prevent infection. Here is our summary chart. Make sure you know summary charts. And our final slide, thrombocytes or platelets. So the number of platelets, numerous platelets are derived from a single cell. So if you think back to our hematopoiesis, when we talked about hematopoiesis, we talked about how the pluripotent hematopoietic stem cell becomes a megakaryocyte. And then that megakaryocyte fragments, and its fragments become platelets. They're anucleate but contain an endoplasmic reticulum, and they produce clotting chemicals. Function, they are clotting cells, and they're activated by chemical signals. When there is a cut in your tubes, in your circulatory system, those cells will release chemicals that activate these thrombocytes. Summary chart again, and once again, if you have any questions, please email me, let me know how I can help you, and have a great day.